We start. Welcome to the KYON webinar about fracture plating and infection, a guide to reduce the most common complications. So first of all, thank you very much for your interest and your time. My name is Guy, and I'm since beginning of 2019, I'm the CEO of KYON, and I'm very proud to lead such an amazing company with talented people, leading edge products, and partnering with all of you, our veterinary professionals around the world. So KYON will keep its core values, and one of them is to provide you exemplary education to achieve best outcome in your daily activities. With our webinar series, we take the chance to let you profit from the knowledge of our experts also on the digital way. So today, I'm excited to announce our speakers and experts. First of all, Dr. Otto Lanz, professor at Virginia Tech, Slobodan Tepic, the founder of KYON and member of the board of directors, and also on board is Steve Brezina, our chief technology officer, who will manage and moderate your questions after the two talks. So please feel free to raise your questions throughout the two presentations in the chat function as shown on the screen for desktop or mobile versions. And we will have time for those at the end of the two presentations. So let's get it started, and I wish you a great learning experience. I'm handing over now to you, Slobodan, for the first talk.
Okay, so there are these four, I guess we were here, four design and material points that we'd like to address to look at how this could affect the reduction of risk of infection. Point-like contact to bone is the first point. Locking screws make that possible. Without locking screws, you cannot have point-like contact. In-plane bending is a special feature which actually makes the second point, the locking screws, especially if they're used monocortical, makes it easier, almost makes it possible. In some situations it wouldn't be. And then titanium is our material of choice. From the beginning, we do everything that goes into implants, either in titanium or titanium alloys, because they're superior in biocompatibility. And in the race between the tissue and the bugs to the surface, tissue usually wins, which is most important. It all kind of started back in Davos Institute in late 70s and early 80s. A number of people led by Professor Perrin, who was the head of the lab from its inception basically till about 96, did experiments, and some of them were kind of good luck that showed that the temporary porosis, which used to be accounted for by stress shielding, was not stress shielding phenomenon, but it was blood disturbance, mostly periosteal blood flow disturbance. So again, my slides don't advance. Here is an image of a sheep tibia. It was plated by DCP for 4 weeks. Whatever is blue here is perfused by blood, and what is white here is not. This is dead bone. The better the contact to the bone, the more dead bone you have. A beautiful image from Emmanuel Gautier showing periosteal capillaries just at the time when the blue dye, you see the blue dye coming in there through these nice capillaries, and then seconds later it's all going to turn blue if there is actually blood flow. This is a very nice experiment again that Emmanuel Gautier did. You see a plexiglass plate fixed on the tibia, sheep tibia. This is all in vivo. And this section in the middle was milled up by only 0.2 of a millimeter. And by taking that little bit of a space, there was still blood perfusion in here. This is white here and white here. Wherever the contact of the bone is, this blue dye does not get in. These are fluorochromes that label bone formation week by week, and you could trace where the bone damage is and how it's being repaired. And in this case, all of this bone under the plate was dead. It's being replaced now week by week, going from the periphery towards the center here. which remains dead for weeks. At about 10 weeks time in sheep tibia, the porosity is at its peak. This is 20 weeks later, you see there's new bone, but this is not good bone. This remains porotic for months and possibly years. It never comes back to full healthy bone. Now, if you can do this, either by point-like contact or no contact at all, what happens between the bone and the plate, very quickly, granular tissue fills in the gap. There's plenty of blood supply here. This is only a couple of weeks after, and it's all blue and in good shape. However, if you're going to do this and still have mechanics functioning, you need something else other than normal plates. The way normal plates work, you use a screw as an anchor, you pull the plate down to the bone, and you rely on friction to transfer the load from the plate to the bone and then back to the other side. You need the friction, and you need a really good pull here. If the pull is not enough, it's going to slide, and sliding is always a problem here. You get debris and so on. So the locking screws were the solution to this minimum level of contact, point-like contact. Without it, you cannot do this. If the contact was that small and you use regular screws, you crush the bone and it's not going to work. You also get, by locking screws, some increase in the constant strength. This is not terribly important, but it does help. And we learned that if you use locking screws, monocortical are as good as the long bicortical screws, which protects the endosteal perfusion, as long as the thickness of the cortex is sufficient. In most cases, the aphyseal bone and so on, there's plenty of cortex for that. Once you're near the joints, you need longer screws. So this is the load transfer by a locking screw in a plate. The plate is pulling this way. You go across the shear here, and the screw pushes like a peg against the bone. And if you had a long screw, it really would be for no use mechanically. So the way that the point contact was achieved was by undercutting the plate here longitudinally with a sharp arch here, and then these arches going across the plate all the way, which left only little contact here, 2 points per screw. The preclinical work done in Davos over more than 10 years was done in vitro, looking at all the mechanics of BC fix, as we call that whole project, versus DCP and LC-DCP. Most of you are probably familiar with that. And then the in vivo experiments done to look at the healing of bone were done on sheep tibia, comparing PC fix to DCP and LC-DCP. These were very demanding experiments. We went as far as 2 years follow-up, starting at 3 months and all the way up to 2 years. The infection study, the model for that was a rabbit tibia, and we looked at stainless steel versus titanium, but we also looked at the design of the implant, comparing PC fix to DCP. So here's a fractured tibia. The fracture was here, fixed with a lax screw. You cannot see perfect reduction here, and then plated with a 7-hole plate. This is 12 weeks later, the animals were killed, and we always had the contralateral healthy bone, comparing it to this for mechanical testing. And you can see that the healing here at 12 weeks was complete, judging by X-ray and then by mechanical testing. What you see here is at 12, 24, 48, 96 weeks, so this is almost 2 years here. Each group had 6 animals, and the red is DCP, conventional plate, and blue is PC fix. So at 3 months, only at 3 months, there was no refracture through the original fracture. The plate is removed, the bone is broken wherever it's weaker, and all of the DCP, 6 of them out of 6, failed through the original fracture at a very low strength. So the healing was not progressing. And then at 6 months, a little better, 2 out of 6, and still 1 a year, 2 out of 6, and then 1 out of 6 at 2 years. There was only 1 PC fix bone that ever broke through the original fracture at 2 years. Now, the reason for this is rather clear once you do careful x-rays and histology and all of that. This is the fracture zone here at 3 months after fracture and fixation. And this is DCP. This is your classical plating. And by the way, this is what you're going to see with just about any plate that's on the market today, either for human or veterinary, because as hard as they try to present it, they still make contact to the bone, big enough to cause this. This is necrotic bone. It's running about a third of the cortex all the way under the plate, and it cannot heal. If you look at the cross section, this is between screw holes, PC fix at 3 months. There's no damage in the extant cortex, just nothing happens there. This is bone growing from the plate down towards the bone and from bone towards the plate. With DCP, you see this massive porosis under the plate. This is dead bone. Dead bone is the place where the bugs are hiding. There's no blood supply there. There's no defense of the immune system. There are no antibiotics that get in there. And this is what causes these long-term infections. The infection studies were done on rabbits, as I mentioned, and we see here titanium plates. We also looked at stainless steel, and these were fixed with 4 screws to the medial side of the tibia. And these little holes were used to put the bugs through the hole and then put a plug on top of that. So a controlled dose of bacteria was delivered here, closed up, and then we watched what happens weeks later. You see blood perfusion again under PC fix is almost intact. And with the DCP, this bone is not perfused, it's dead. And if you get bacteria in there, they will just be there forever. If you look now at the inoculum size, this is colony forming units here on this axis versus number of infected bones in a given group. So 6 out of 6 here, this inoculum here. The red is showing you the DCP infection gets up to 100% with this inoculum size. At that same level of inoculum, PC fix is only 50%. So we compared the 50% risk here, and this was DCP in stainless steel. I'm sorry, I need to back off here, versus DCP in titanium. This picture here is titanium versus steel. Now, if you look at PC fix, so the underside of the plate now is compared. This is the red one is PC fix, the blue is DCP. You summarize this and you see that the material gives you factor 10 increase in resistance as far as colony forming units to get 50% infection. But the shape, contact to the bone, is more important. It's factor 100. So you combine these two, you get about factor 1,000 reduction of the risk at a given level of bacterial challenge. Now we can say, well, does that matter, 50% infection? Here's an interesting study from Davis published in 1989. They looked at the infection after plate removal 16 months later. 40 dogs had plates removed, and over 40% of those were positive, even though there was no sign of infection, no systemic sign. The bugs are there under the plate in this dead bone. If you look at the control with no implants, it's only about 7%. Now, the preclinical studies took about 10 years at the Davos Research Institute with all these people, most of them human, but some veterinary surgeons as well. Stephen Brezina was there for most of the time. We've done 250 sheep with, as I said, up to 2 years follow-up, and we've done 400 rabbits looking at the infection risk. A lot of work, many, many years. And this was the basis when we talk about ALPS. KYON or any other company of this size could not possibly do basic research of this scale. This was all done at the Foundation Research Institute in Davos, funded by today kind of Synthes, DePuy, whatever that big company has become. It used to be 3 smaller. Now, what are the outcomes of all those preclinical studies? Well, the PC fix treated fractures heal much faster, 3 months versus 1 or 2 years with DCP or LC-DCP, and consistent healing, no porosis in the bone anywhere. The difference between DCP and LC-DCP was not there. We could not demonstrate any advantage of LC-DCP over DCP. This remained unpublished. It's one of these sad things about research where the commercial interest, because LCDCP was on the market now, it was no better than DCP. This was never published. Now, PC fix can spare blood perfusion, both periosteal and diasteal. This was very clear. This doesn't need to be discussed in any way. And resistance to infection was hugely higher, both in local challenge and systemic challenge. There was another study done in Sweden at Karolinska with systemic challenge with bacteria. Showed an incredible difference between the two groups. Now, the clinical study is actually started with Pierre Montavon at the vet school in Zurich, doing clinical work on fractures in dogs. And he did over 50 cases in about a couple of years. And then the large scale forearm fractures study in 24 clinics in Europe, the aim was to do 2,000 cases. So this was clinical study. So here's one of the cases that Pierre treated, a typical long spiral fracture of the tibia, fixed with what? One screw across the fracture here to bring it together. And then at that time, everyone was trying to use only 2 screws on each side of the fracture. This biological fixation was in vogue and everyone wanted to use less screws. We do not recommend 2 screws. We say 3 monocortical on each side will make it much safer. That's based on experience, not on some sort of mechanical analysis. The human study was published by the time there were 1,170 fractures here. And in open fractures, the infection rate was 1.6%, in closed fracture, 1%. How does that compare to other plating? Well, that's the problem. This was not a comparative study. And so it was almost pushed aside, like this is irrelevant, because the old guys that were running AO, they said, well, we always have just 1% of infection, which is obviously not correct. Now, here's what happens in 2000. The LCDC plate is modified now to allow locking screws with the threaded head of the screw. So now you have this combi hole. You can use either compression here or regular cortical screw, and here you can put a locking screw. This became standard. Synthes led the way, and once Synthes leads the way, everyone follows. These cuts here don't go across, they're just side cuts, and the middle is what it was in LCDCP and never had any advantage over DCP. But the message from those decades of work culminated kind of in early 90s with the message, keep the bone perfused. This is again, slide from Emmanuel Gauthier there. It turned into something like this, lock the screws. Everyone is locking the screws, but locking the screws for the sake of locking is not of any real value. You lock the screws if your contact to the bone is reduced. And in all those lock plates that are out there on the market, other than ALPS, the contact is still there, too big a disadvantage. If you haven't seen the movie Lost in Translation, go and see it. It's one of the best movies ever, by whatever I like in movies. Now, until ALPS came out, there was no sign of PC fixed. We came out with ALPS clinically in 2007. The patent was filed 2 years before that. We took some time to develop it, and it replicated all the features of PC fix with 2 additional benefits. You could use regular screws, either neutral or compression from either side in every one of the holes, or you can use locking screws. So with this plate now, you had PC fix with added advantage of using regular screws if you wanted to, and you could also bend it in plane. This was a new feature as far as long bones go. And in-plane bending makes your use of monocortical screws much easier because you try to put the plate on top of the bone. And you can't do this unless you bend the plate in plane. So with this now, you can target your screws. Either you put it in if the bone is there, if you bend the plate, or you don't use it. And you should be able to find 2 to 3 holes on each side of the fracture for that. Versatility in use, you don't need special plates. This is not common in veterinary, but it is very much in human. And the design space, what we could do now with the side cuts to get uniform strength. The plate is a little stronger at the screw hole than between the screw holes. could do this better once the plate has these side lobes the way it is. So this is ALPS 1, as we call it now that we have ALPS 2. And this little bit of a bend here in plane allows you to put your screws where they should go, in the middle of the bone. You're not coming off here, coming off there or there. And then you have to angulate. So with this, pretty much angulation of the screws became almost irrelevant. The sizes were all there in due time. We had whatever from 5.0 and then later from 3.5 and 4 and so on. We have all these sizes now. The plate that was studied in detail by Steve Resina was the size 10. ALPS 10 was meant to replace or be equivalent to 3.5 millimeter DCP in stainless steel. And the analysis which Steve did showed that in fact this was stronger than this. You can see these red points here. This is the stress concentration that comes around the DCP holes. What was the difference? Well, 20%. So the ALPS 10 with the same width, the same thickness as the 3.5 stainless steel plate, they have made it since thicker. It's now another 0.5 millimeter thicker. Not sold in human business anymore, but it is for vets. This plate was 20% stronger by calculation. And Randy Budrio did this large study comparing all sorts of plates. These are all Synthes plates here. DCP 3.5 stainless steel was our benchmark. We matched that and exceeded it by 20% with ALPS 10. And with ALPS 11, we cover just about everything. This is bending strength. If you look at the strength when the gap is limiting the formation of the plate, which is how plates usually fail, then ALPS is 175% stronger than DCP steel because titanium has just slightly lower strength as material, but it is half in modulus, so it allows much bigger deformation. So if you look at the stiffness here, yes, ALPS 10 is much softer than stainless steel 3.5, but you take an ALPS 11 and you cover all of these plates, which by the way are much larger than these. They've gotten wider and thicker. So we cover the range at least of what Synthes has, and that's pretty much what everyone is looking at. And if you have the same external dimensions, ALPS are stronger than stainless steel, DCP, LCDCP, or any one of those. Now, why did we go to titanium? Because titanium, of all the metals that people have looked at and studied for decades, has about the best biocompatibility. It is inert in the body. Stainless steel is as well inert unless there is fretting. But when there is fretting, which is very frequently the case, you get ions and you get nickel out and you get chromium, and this is all bad. Titanium is not doing any of this. It's supersaturated, never dissolves in the body fluids. We usually make plates out of grade 4 pure titanium. Screws are out of titanium alloy, which is about 60% stronger than either grade 4 or stainless steel. We do micropeening, which is not normally done. It's a nice process, gives you about 20% increase in fatigue strength. We anodize them all so they're not just color-coded, but actually they're nicely cleaned by this anodizing process. The first real reports that were published later came from Japanese people. They were the first to start using ALPS in 2007. All of our Japanese clients got going with this. Yamaguchi presented at VRS 2013, and his resident Nojie, she presented at our symposium 2013. The paper was then published a couple of years later. There was only one infection out of 271 that were not infected at surgery. There were 11 known infected secondary surgeries, revisions. In those 282 total, 9 of them healed without a problem in one go, and 2 got amputated. If we add to this reports, which are personal communications, so not published yet, from 3 other Japanese surgeons, we end up with about 2 out of 670, whatever. Now this is well over 1,000 still, and it's about 0.3% infection. That's as much as we can say with some good certainty. The our TPLO has the same advantages as ALPS. The underside has the features, the locking screws, all of that. And in 2017, 2 years after we started with 6 clinics, we had 3 infections out of 1,000 cases. I just called 2 of those clinics a couple of weeks ago, and they're still at 3 out of 1,000. Those 2 are participating here amongst these 6. We'll update this. But you look at all of this together, it's about 0.3%. So why did we do ALPS 2? Well, not because of infection. You cannot get better ALPS 1, ALPS 2. They're all going to be the same TPLO. But we were looking now to base all our screwed implants with the KYON locking screw system, so that if you have ALPS, you can do TPLO, or if you have TPLO, you can do ALPS. It's a great help because screws are the largest burden to getting going with something new. We will keep supporting the original ALPS, but we're also bringing the new ALPS, ALPS 2, to the human use. About 25 years after PC Fix was supposed to be brought out, but it never was. We also have now what we call ALPS 2S, where the plate is also made out of alloy, which is about 60% stronger. Maybe in some cases this is going to survive, whereas this one would not. It's a difficult thing to judge. It's always your surgical skill and all of that. And if you go to YouTube, these 2 I suggest you look at. This is KLS story and ALPS history, each about 5 minutes. Take those 10 minutes time and watch this. You're going to get a lot more detail that I could not present. So keep the bone perfused. And thank you. I hope you managed to hear and see this. Thank you.
We did, Slobodan. Thank you very much for that insightful presentation. So again, just want to remind you, if you have questions, please add them in the chat function, and we will follow up about the questions at the end of both presentations. So I would say let's try again and jump directly into the second presentation from Dr. Otto Lanz. Hopefully it's working this time. Otto, it's your turn.
Okay, hopefully you guys can hear me. I think this is where I left off, and this is just continuing on what Slobodan said about making sure you preserve the blood supply in the periosteum. And again, not only is it from the plate, but it's from the surgeon as well. So using point-to-point reduction forceps, trying to avoid current reduction forceps will also help quite a bit. So again, this is what I was explaining, just making sure that you do have good contact with the plate against the cortical bone is important. And also remember that the screws themselves are going to compress the plate to the bone. So in some cases, especially if you're using the TPLO plates where you may not have exact contact, you can place either a freer or an instrument and then tighten the screw, and it'll maintain your reduction as well. There's also a peg that you can place into the hole of the plate to put a pin just to temporarily hold the plate so that you can check your contouring and then go ahead and replace that with the screw at the end. Another important aspect, and I see this a lot in some of the cases, is just make sure that you're using the appropriate size plate for the fracture for the case that you're doing. This is just a rough guideline to use, but again, what you want to make sure is that you're not using too small of a plate for the weight of the patient that you're doing. And again, this is comparable to Synthes as well. Guy, are they controlling the advancement?
Right, they're controlling it, but
okay,
I don't
so
know.
They can go ahead and go to the next slide.
Right, it should be the next one, so hopefully,
hey,
yeah.
Okay, another important thing is to remember preoperative planning, whatever software you use, if it's Horos, if it's Brightbox, or if it is a VPOP as well. I do believe in preoperative planning. It helps you to make sure that you have the plate that you're going to use. In some cases, if you take a radiograph of the non-affected side, or if you have a bone model, you can go ahead and pre-contour these plates, which is important. And again, make sure that you pre-contour these in plane first and then out of plane, which we'll go over in just a bit. You can go ahead and advance it. One other aspect to remember is in some complicated cases or comminuted cases, just make sure that you get bone graft. The proximal humerus is the easiest to get an abundant amount of bone graft. Again, the advantages of the bone graft is going to expedite bone healing through osteogenesis, induction, conduction, and promotion. You can go ahead to the next one. This first case, this is just to demonstrate the ALPS on a radial fracture. This was a comminuted radius ulna fracture that has cranial and medial displacement with some fissures. And again, what was used in this was an ALPS that was placed dorsally, and if you can advance that. And here we see the cranial placement of the plate. Again, not every screw does need to be used. The only critique on this that I would say is just make sure in the very most proximal screw, you can see that the screw does go a little bit into the ulna. You want to try to avoid that. You can use monocortical screws in this, which work quite well. And again, 3 monocortical screws proximally and distally is all that you need. We can go to the next one. Okay, and this is a second ulnar case. This is not as comminuted. It has this minor comminution and a small fissure of the radius and ulna. We can go ahead and show the next. And again, this is another ALPS plate that was used. And again, the good thing about this is that none of the screws do penetrate the ulna, which is important. Not every screw is used. We have good contact with the plate and the radius itself. If we advance this one, here we can see at 8 weeks post-op that we already have a bridging callus of the radius. The ulna sometimes will take a while to heal, but in this case, it did eventually heal. Again, this is a very simple way to place the ALPS is on the cranial surface of the radius. And if we go to the next slide, the other possibilities that you can do for radial fractures is to plate them medially. The advantage of plating them medially is that you can use longer screws and get better screw purchase if you do go bicortical. Again, not necessary. The other big advantage of this is that you can avoid the long digital extensor tendons and all the extensor tendons. The other possibility, we're going to get into this in just a bit, is dual plating, meaning that you can put a plate both on the cranial surface of the tibia and on the medial surface. Again, this has its biggest use and advantage if you're doing very distal radius fractures where you can't get very good screw purchase. Again, just placing one on the cranial surface and on the medial surface will help you achieve sometimes 1 or 2 screws into the distal aspect of fragment. The other advantage of using the ALPS system in this is that you can use a monocortical screw if it is angled or directing you into the joint surface itself. If you can go to the next one. This is an interesting case. This was a case that was referred in. It was 3 weeks post-operative from a tibial fracture, and this had a 3.5 DC. No, this was just a 3.5. I think it's a DCP plate on this case. And at 3 weeks, we can already see failure of the plates. And we'll go into why this failed, into some of the problems that can be avoided in these cases. If we go to the next slide. So if we look at stress as the force per unit area and the strain is the change in length over the original length, the biggest issue with this, and I'm sorry, but I can't draw on this screen, or I don't know if I can even use my cursor, but if you look at the lateral aspect of the tibia, it was not reconstructed, and this is actually going to increase the stress and the strain of the plate, mainly increasing the stress by decreasing the unit area, meaning from the plate to the lateral cortex is not, it's not reconstructed, so the only thickness or the area is going to be as thick as the plate. The stress and the strain led to, again, fatigue or cyclic loading of the plate, which led to the fracture of the plate. If we go to the next slide, please. Okay. The other thing that's affected is the bending moment, especially if in the case of the tibia, if the lateral cortex was not reconstructed. And what happens is that if the bending moment is defined as the force times the distance between the plate and the cortex or the lateral cortex of the tibia is not reconstructed, the distance is going to be, the D is going to be smaller, which is going to make the bending moment greater. But if somehow we can artificially reconstruct the lateral cortex, and the two ways of doing this, one is, which is most commonly used, is to do a plate rod construct, whereas if we do a plate rod construct, that's going to increase the area and the distance as well, which is going to decrease the stress on the plate and is also going to decrease the bending moment. Dual plating is another possibility that can be done, especially in cases where you have a very distal fracture or a fracture that's close to a joint. Can you advance the slide, please? So in this case, what we did for the revision, and this is the ALPS 2S, is that we used 2 plates, and again, we placed a 10 ALPS and a 9 ALPS cranially. The 10 ALPS was on the medial aspect of the tibia. Again, 3 screws, approximately 3 screws distally. Did these need to be bicortical? No, you could have used monocortical screws, but in this case, we decided to use bicortical screws. And then the plate proximally is increasing the area and increasing or decreasing the distance, which is in a decreased bending moment and the stress on the plate. Again, it would be nice to put that plate more proximally, but again, with the flare of the tibial crest, sometimes that makes that difficult. And you can go to the next case. And again, this is 4 weeks. Let's go. If you can go back one, please. And this is 4 weeks post-operative on this case. And again, we can see that bridging callus is forming. We do have at least healing of the fracture. And at 8 weeks, this was completely healed and the dog did return to normal function. If we can go to the next one. This is a tibial fracture that again looked very routine, and this was repaired with an ALPS 10. If we go to the next slide. Again, if you look at the lateral radiograph, we can see that we have, you know, good reduction and good alignment. And you look at the cranial caudal, in this case, actually a caudal cranial of the same fracture, we do have good reduction, good alignment. The problem with this fracture, and this is just to point out some of the biomechanics, is that the lateral aspect of the tibia is not completely reconstructed, and there is fissures along there. The other problem with this is that it's very rigidly fixed. It would have been nicer to maybe have 2, 3 screws or monocortical screws further away from this fracture. Putting the screws so close to the fracture lines themselves or the fracture, that's going to put a lot of stress and strain on that. And if we can go to the next slide. Here we can see that at 4 weeks we have fracturing of the plate or failure of the plate. And again, this is just due to cyclic loading of the plate. Hindsight, this would have been one to either use a plate rod construct or to use an ALPS 2S, where we could use just 3 screws, approximately 3 screws distally, and go and at least allow some flexibility in the plate. In this case was actually, it was removed and it was repaired with dual plating as well. On the next case, and this was a Great Dane that was presented after a gunshot fracture to the mid femur, where we have somewhat of a caudal and lateral displacement of the fracture. In this case, if you can go to the next slide. Again, this is an ALPS 11. which is a fairly large plate. And in this case, what we ended up doing was more of a biological fixation of using a plate and a rod construct. The screws are not bicortical, but the monocortical with the pin. And again, this plate rod construct is something that can be used in these dogs that have high comminution. Now, one question may be, yes, this is an open fracture. Why did we decide to use a plate rod construct in this case? And that could be debated. In this case, we just decided to do it given the temperament of the dog, the owners themselves being able to take care of the dogs, but they're adequately warned that we may need to remove these implants. In this dog, a few months later, everything healed, it returned to normal function, and it was not necessary to take out the plate or the pin. We can go to the next one. And this is the last case, and this is a total hip fractured. This was a case that had a BFX implant put in, and a couple of weeks after implantation, the dog did have a fracture just below the implant itself. It was originally repaired with a string of pearls plate, and at 6 weeks that plate fractured, and then it came back in, and this is the original repair of that fracture, and this was done with a 3/5 broad plate and cerclage wires. Again, one thing to notice is you can see this gap distally, especially on the lateral radiograph. Again, this was bone grafted. See what happens, and if you can go to the next slide. And this is 7 months post-operative, and you can see that we have complete failure of the distal aspect of this plate and this fracture. This is, again, why did this happen? More than likely that distal gap just went on to a non-union, which is called cycling of the screws, and which led to the breaking of the screws. And you can see how the screws again are broken or they've pulled out. And if we go to the next slide, this is a horizontal beam where you can see more where we have the shearing off of the screws. The one cortical screw is backed out as well, and we can see where we have collapse and still a non-union that's occurred. We can go to the next slide. And we templated this case, and this is, I did talk to Slobodan about this case, and if we can go to one more slide, please. This is an idea of the bridging plate technique that was used, and this is first described early on, and Slobodan told me about it. And what we did is we contoured the plate, but we left a gap. And the reason that we left this gap over where the fracture was to allow callus and to have minimal destruction of the soft tissue surrounding where the non-union was. So if we go to the next slide, here you can see this is 3 months following that case where we removed as much of the implants as we could. We went ahead and placed this was just a minimal approach and minimal amount of dissection. And here you can see the gap on the craniocaudal view between the bridge and the bone itself. And on the lateral, you can see the same bridging. And then at, if we can go to the next slide. And then at 6 months, we have just a little bit of a gap that you can see, but again, the cortices are intact. And this did go on to heal and do well. And this is the first time, again, that I've heard of using a plate in a, what's called in a bridge fashion. And again, this did work out quite well, and this dog ended up doing well at the end. And I think that's the last case, if you want to advance one more time. Okay. And again, and I know some of these cases could have been handled differently. But again, if you have any questions or anything, you can let us know, and Slobodan and myself and maybe Steve will try to answer them.
Right. Thank you very much, Otto, for this kind of practical presentation. So let's get to the third part of the webinar. That's your questions and the answers for that. So over to you, Steve.
Okay, good. So we have a few questions that have popped up on the question board here. Most of them, Otto, sorry, are for Slobodan, it looks like, but I think you can chime in as well, especially on the point of the first question here, which comes about monocortical or bicortical. You know, in what exceptions would you use a bicortical screw instead of monocortical?
Can I answer that?
Yeah.
Maybe a little demo. The most useful demonstration that I found for this is if you imagine those guys that are free climbing on the rock face, and there's a teeny bit of support, and now they're going to hold their fingers here and lift themselves up. If you can stiffen your fingers and hold right next to your hand here, well, you got the strength. If you had very long fingers going out there, it's not going to help you because they're compliant. This is where it matters. So if you can get a good hold of your cis cortex here, that's sufficient. The only limitation here is, do you have enough thickness of the cortex so your screw has a decent purchase against pullout? Now the pullout depends on the length from the screw to wherever else is going to, be pulled off the bone. And the tendency today is to use longer plates. Once you have a plate that long, the screw is going to hold against pullout. The plate just can't take it out. So this is why we like monocortical screws. But when you're near the joint, the cortex is very thin, fraction of a millimeter, and that's not going to give you enough grip. Then you go for a long screw, you catch the outer cortex, and you resist the pullout. That's usually the case because the fragments are very short. Experience is basically vast and very positive on this. You cannot do monocortical screws with regular screws. It just doesn't work. People have tried that decades ago, but the screw is wobbly, right? If it's not locked, it can do this. And then it's like you're trying to get a nail out of a piece of wood and you just wobble it and you get it out. Okay?
Great, thanks, Slobo. Next question is, what if you use screw plugs in the holes in the plate at the fracture site? Would that help increase the strength of the plate?
No, because the plates are designed so that without the screw heads or plugs, whatever, in the holes, the plate is stronger at the hole than between the holes. So you would be just wasting plugs.
That's especially true with ALPS 2, where the hole size is smaller.
And 2S, right?
Right.
Say again?
With the ALPS 2 and 2S compared to ALPS 1, the screw hole is actually smaller. So the plate is actually stronger at the screw hole more than it was in ALPS 1 with the 2.
Even in ALPS 1, it was stronger, and then now it's even more. So there's no reason to put any plugs in the empty holes.
Then another question, Slobo, is about the study done in Davos about, can you explain why there was no difference between the DCP and LC-DCP plates in terms of the bone healing?
Well, the LC-DCP still made too much contact to the cortex. In the middle of the plate, between the screw holes, there was still a strip of plate that would touch the cortex. And even if it's 3 millimeters or so, whatever the width is there, it would kill enough bone that the fracture could not heal right there. And this is the critical stress concentration right under the plate. The opposite side is never a problem if you have good support, if you can reconstruct the fracture. But with the regular plates, the near cortex was always at risk. And so PC Fix solved that problem because those bridges go all the way across the plate.
Great. There's a question about mixing metals. For example, do you see any concerns about using stainless steel pins with titanium plates and screws? Otto, what is your feel about that?
I mean, I have not, and we're asked that a lot about, especially a plate rod construct. I've asked other surgeons, and in the follow-up, I haven't seen it as a problem. There are some human articles, especially out of JBJS, that have looked at it, and they haven't seen a problem with IM pins and pins in titanium. And the other is when people have prophylactically plated femurs following total hip replacements using stainless steel or 316L plates, have not seen a problem either. And I don't know what, Slobodan, if you have more to add to that, or.
Slobo, you're muted. Slobo, you're muted.
Yeah, clinically, it's very hard to demonstrate a problem. There was a targeted study a few decades ago down here in Switzerland, and they couldn't tell the difference. At that time, titanium was very exceptionally used only for people that had allergies to nickel. And so not everyone had all the materials at hand, so they would use stainless steel screws and titanium plates and stuff like that. So it's not recommended, but it's not going to cause a big problem.
Good. Then there's a question about the feel of the titanium plates. They say they bend much easier than 316L plates. Are they weaker plates than stainless steel?
They're not weaker. I covered that in the presentation. Please go back and look at that when you get the slides. Titanium plates are more flexible because titanium as material has the half of modulus of stainless steel. So it flexes a lot more, but that's good if the flexion is going to break the plate, which is very often the case. So there's really no way to tell that titanium is a problem as far as strength goes. I may mention here quickly, there was a study at Texas A&M, and they compared in many fractures done at that school, stainless steel versus titanium. It was not ALPS, it was, I suppose, Synthis, which was not used in veterinary circumstances much. I mean, it was just human stuff, right? And they found that there was more problems with titanium. But please, if you can find that abstract, it's probably somewhere, I think it was ACVS. The mechanical failure in the hands of those residents, surgeons, whatever, at Texas A&M, was close to 50%. Every second construct they put together failed. And so titanium was 50 or 48% and steel was 46. Well, if you're counting on saving your day and every second one fails one or the other way, you better go and learn how to do fracture fixation. This is a sad example of one of the leading universities, because that was definitely, Texas A&M was there from the start. And how come that every second fixation fails? I don't know.
All right, thank you, Slobodan. Otto, here's one for you, and it has to do with what is your recommendation of the screw positions with the working length of the plate, you know, when you're repairing a comminuted fracture versus a simple fracture? You're muted. Otto, you're muted.
Now you can hear me?
Yeah.
Good. So, I mean, that's a difficult question to answer for one reason. There's no real reports on monocortical screw and screw placement and screw density. For comminuted fractures, I do follow the principle of using the longest plate possible and using, again, one screw close to the fracture line and then further away from the fracture line, and just trying to use a minimal amount of screws, so 3 proximal, 3 distal to the comminution itself, and either using dual plating or a plate rod combination. And if, you know, going more towards, if the, you know, the length of the plate, again, using the longest plate that you can, and if it's in the cancellous bone, I do use a bicortical screw in the cancellous bone, and then towards the diaphysis, I use monocortical screws. And again, either dual plating or plate rod construct.
I had a
good.
comment
You've
here.
come back up. Slobo, you're going to add to that?
I'll add a quick comment because Urs Weber, who is one of the best surgeons, most experienced surgeons in Switzerland, had this gut feeling that coming close to the fracture site with screws is better than going away. So Simon Niederhauser, who was the resident with Urs, and I did this study looking at where should we put the screws, with the pin or without the pin. It's mostly cat femurs. And to surprise of Urs and myself, I thought we should get those screws near the fracture, okay? It turned out that going away was not only easier because you're talking now about sliding the plate under the tissues and all of that, but it was stronger in both bending and in torsion with a pin in there. There is a way to explain all of this, and I would say, having seen this, we broke all sorts of models for this. We put together for that particular study. There's a way to explain this. So you really don't like to come close to the fracture. People that are doing this MIPO stuff and so are happy to learn that if they have heard about it. I think it was published. The paper is published. So Simon Niederhauser was the first author on this.
Thank you. Guy, you wanted to cut in here. I have just one more quick question, and then I think we could wrap it up from my side. And that is to you, Slobodan. It is going to be about talking about monocortical screws. Why don't we use monocortical screws in the Paul system? So somebody knowing our Paul system and that we use bicortical screws there, why don't we do monocortical screws in that?
I wonder, it's only 10 years that we're wondering about this. I know that Andy Torrington, who started early with Paul, and we didn't have any instruction courses or anything, he did a few cases with monocortical screws, and they all did fine. And because the mechanical demand on that plate with the cut of the ulna, with a very sort of unfriendly situation there, open gap and so on, we were just scared to even try. And if you don't try, you're not going to see it. So out of those few thousand cases that were done, I think only the few that Andy Torrington did, and they did well, were done with monocortical screws. So unfortunately, we're just chickening out on this. Who's going to try it? It might be good enough. It might be better because you still need all the blood you can get there.
Great, thank you.
Good, thank you very much. And we're run a little bit over, but I think with some challenges at the beginning, sorry again for that. I would like now to take the opportunity to thank you, our experts, Otto, Slobodan, and Steve, and as well all attendees for attending that one, and as well, especially like the KYON team to making this webinar happen. We hope that we met your expectations and that you learned a lot about new practical insights, tips, and tricks. So just a few final points, 3 points. As soon as the webinar closes, there are 5 questions. We would appreciate to get your feedback. Secondly, if you are interested to get further information on the webinar, education events, product or launches like our new acetabular fracture plate and a lot of other things, please subscribe to our newsletter on our website at kyon.ch. And finally, the third point, you will receive, as mentioned before, an email with the presentation very soon. And if you have further questions, we are here for you to support you, and please contact us directly. So I wish you a great afternoon or evening. Thank you very much for attending again, and have a good day. Bye-bye.